In triple-negative breast cancer right now, the first-line setting is to do a taxane, or you could do gemcitabine carboplatin and add in pembrolizumab, depending on whether there's a PD-L1 positive cancer or if it's negative, to just not do pembrolizumab right now. You could also consider, for those patients who have BRCA mutations and are PD-L1 negative, you could consider doing a PARP inhibitor. In the second and third line settings right now, we use ADCs primarily, sacituzumab, govitecan in second line setting, which was studied originally in the ASCENT trial, has an excellent median progression-free survival. It's an ADC, an antibody-drug conjugate, that has a TROP2 antibody tied to a topo-1 inhibitor. Sacituzumab govitecan is interesting because the linker is hydrolyzable, so it kind of falls apart in the bloodstream, and it can also be taken into the cell, and that chemo can diffuse back outside the cell, so it does have chemotherapy side effects. The main side effects for sacituzumab govitecan are the hair loss and also myelosuppression. It's dosed on day 1, day 8, and then for a lot of us, we're doing a pegfilgrastim or some kind of filgrastim to support their blood cell counts. In the ASCENT-04 trial, which was discussed at this year's ASCO, sacituzumab govitecan plus pembrolizumab was a positive trial when compared with the current standard of care chemotherapies. And so it's expected that sacituzumab govitecan plus pembrolizumab will move into the first line setting. So with that therapy, I think it's very important because that therapy is better now than, or at least in terms of median progression-free survival, is considered to be superior to treatment of physician's choice. What are we going to do in the second line setting if sacituzumab govitecan is our first line? So some considerations will be, do we use an antibody-drug conjugate afterwards? We have trastuzumab deruxtecan approved, of course, or do we use a taxane or gemcitabine carboplatin and then sandwich that before we go on to the next antibody-drug conjugate? Right. So in our patients who are triple negative, primarily they're getting taxanes right now, but you can only use taxanes for so long, primarily because of the neuropathy that develops with time. So if someone has a taxane plus pembrolizumab, you would do a taxane for maybe 6 cycles or until the neuropathy develops, and then continue with a maintenance pembrolizumab. If you're just doing a monotherapy with a taxane because they don't have PD-L1 positivity, then you would switch to the second line therapy at that point, which is sacituzumab govitecan now, but in the future we're going to have to reevaluate that.